Hello, my name is Nara Higano, and I'll be presenting our group's work on retrospective respiratory self-gating and the removal of bulk motion in pulmonary UTE or ultrashort echo time MRI of neonates and adults, which was recently published in Magnetic Resonance in Medicine. This work comes from collaborators between Cincinnati Children's Hospital, University of Wisconsin-Madison, and Washington University in St. Louis. Pulmonary morbidities are present in over 60% of our neonatal intensive care unit, or NICU, patients at Cincinnati Children's Hospital, but these morbidities and their time course are poorly defined and understood. Common morbidities include bronchopulmonary dysplasia, or BPD, and congenital diaphragmatic hernia, or CDH. The current standard of care for these infants includes chest x-rays for longitudinal monitoring and management guidance. In more severe cases, CT scans are used to further define the underlying pathology. There is an inadequacy in clinical ability to reliably predict later outcomes. As well, there is increasing recognition that CT can expose patients to sufficiently high doses of ionizing radiation to increase cancer risk, particularly for longitudinal studies and particularly in pediatric populations. MRI is promising as a technique for longitudinal evaluation of pulmonary diseases and function. However, structural lung MRI is challenging and currently plays a limited role in clinical diagnosis of respiratory pathologies. A major challenge is the low proton density of the lung parenchyma, which is about 20% of muscle density. As well, magnetic susceptibility gradients at air tissue interfaces within the lung parenchyma result in a short T2 star on the order of about 2 milliseconds at typical field strengths. This requires rapid data sampling after spin excitation and maximization of K-space coverage while minimizing the acquisition time. The long pulmonary T1 requires small flip angles or long imaging times, and image quality is further degraded by respiratory and cardiac motion, particularly in neonatal populations. For these reasons, pulmonary MRI has historically been challenging. However, effective evaluation of pulmonary disease using MRI has benefited from the recent widespread development of ultrashort echo time, or UTE, techniques that use a variety of radial K-space sampling schemes. These techniques not only provide increased signal-to-noise in the lung parenchymal tissue by minimizing the echo time, but they also are more robust against respiratory and cardiac motion as compared with Cartesian acquisition schemes. This is because the low-frequency K-space is oversampled with radial schemes. The repeated sampling of the K-space center, K0, is also advantageous for a second reason, which is that the magnitude and phase of K0 are modulated by motion. In this work, we will exploit this phenomenon in order to explore respiratory gating and bulk motion removal. Here we show the K0 time course, or what we will call the motion tracking waveform, over an entire neonatal UTE MRI scan. This plot shows the phase waveform, which looks similar to the magnitude waveform. We see clear evidence of quiescent breathing periods, along with periods of bulk motion events. If we zoom in on an interval of quiescent breathing over 5 seconds, we see a clear modulation that matches the respiratory rate of a neonate, which is about 1 Hz. The gray data here represent the raw, unsmoothed K0 phase data. We can process this raw data to yield retrospective respiratory gating using a sliding window binning algorithm. So first, the raw data waveform is smoothed with a Savitsky-Golay sliding window average filter. Then, periods of bulk motion are identified using an estimated breathwise respiratory periods determined from automatically identified local maxima and minima. We will discuss bulk motion a little bit more later. Next, remaining acquisitions from quiescent periods are binned to specified acceptance windows, and this is performed with a few steps. A 16-second sliding window is applied at T0, or the first quiescent point. Data in this window are binned into quantiles, here shown in quartiles, according to amplitude. This window binning is repeated at every time point within the quiescent period, such that each point receives many bin assignments. Finally, raw data points are assigned final bins equal to their mean bin value. Here, shown in color, are smoothed quartile bins, or 25% acceptance windows of the respiratory cycle. This gating scheme requires no additional data beyond that needed to produce ungated images, and it maintains a high temporal resolution equal to that of the scan repetition time, 5 milliseconds, both before and after filtering. Furthermore, a true steady state is maintained. From these uniformly sampled subsets of K-space, we can reconstruct retrospectively respiratory-gated UTE MR images. In our study, we recruited 6 healthy adult subjects for technique validation and imaged them with UTE MRI on a conventional adult-sized GE 1.5T scanner. Shown here is an ungated reconstruction, along with the gated images binned to 25% acceptance windows. The respiratory excursion of the diaphragm is very apparent, with smaller acceptance windows demonstrating more tightly gated images. From these respiratory gated images, we can get multiple pulmonary functional measurements like tidal volumes, respiratory rates during a scan, synchronicity of right-left lung excursions, and also upper airway dynamics. In this work, we validated tidal volumes and respiratory rates from UTE MR-based measurements against measurements from a standard adult pulmonary function test, with good agreement across the cohort. One may point out that there are several well-established methods for respiratory gating in adult MRI, such as respiratory bellows or pencil navigators. However, it is important to understand that monitoring respiration in neonates is much more difficult. The neonatal lung is only approximately 5 centimeters in any direction, with diaphragm displacements of only approximately 3 to 4 millimeters. So these breathing excursions are too small to be picked up by traditional bellows or navigator techniques. So our UTE self-navigation methods represent a more sensitive and effective method for monitoring neonatal respiration. After adult technique validation, we performed similar imaging and analysis on a NICU infant cohort with control, BPD, and CDH babies. This imaging was performed on a neonatal-sized 1.5 Tesla scanner, which is sited within the NICU of Cincinnati Children's Hospital, and it operates with GE HDX software. Similarly to the adult data, we can reconstruct neonatal respiratory gated images from free-breathing, non-sedated infants, which again demonstrate expected anatomical respiratory excursions, and again allow us to measure certain pulmonary functional measurements like tidal volumes, which are difficult to obtain in infants without using sedation or invasive procedures. This motion tracking waveform can be used for more than just retrospective respiratory gating. It can be used to detect and retrospectively discard intervals of bulk motion from image reconstruction. Again, it is only possible to do this from a temporal subset of K-space data because our radial data is acquired with randomized trajectories. This capability to retrospectively discard motion-ridden data is particularly important in the neonatal population. We cannot ask an infant to simply sit still through an MRI scan, and as you can see from this neonatal motion tracking waveform, these infants often decide to wiggle in the bore as they please. As proof of method, we again imaged a healthy adult volunteer to show that we can throw away motion-ridden data to improve UTE image quality. In addition to UTE data, we also acquired Cartesian gradient echo images. So this adult volunteer was asked to perform 2 sets of instructions for both the gradient echo and UTE scans. For scan 1, the volunteer was asked to sit still and breathe quietly. As you can see in the images, both types of acquisitions demonstrated reasonable image quality, and the UTE motion tracking phase waveform demonstrates quiescence, as expected. For the second set of instructions, the volunteer was asked to behave like a neonate might, i.e. remain in position 1 for 100 seconds, shift and remain in position 2 for 100 seconds, and then perform bulk motion with chest shifts for the remainder of the scan. We can see with this set of instructions that the gradient echo quality is significantly degraded, and that the UTE quality is slightly blurred. The motion tracking waveform very clearly reflects our sequence of positioning and motion for this second scan. We can reconstruct the UTE images with selective K-space data from just positions 1 and 2, which the data is shown in black here, and we can throw away the data acquired during bulk motion, here shown in gray. By throwing away this data, The parenchymal signal-to-noise has been exchanged for improved spatial resolution of the anatomy. The green arrows point to a doubling effect at the anterior lung wall and anterior chest tissue, which is reflective of positions 1 and 2. We can further reconstruct UTE images using only data from position 1, again shown in black. These images demonstrate further decreased parenchymal signal-to-noise, but a clear increase in structural detail as compared with UTE images reconstructed with the motion corrupt data. We can perform similar processing of bulk motion for UTE scans with non-compliant infants. In conclusion, this work represents the first application of the case-based center to track and discard motion-corrupt UTE MRI data, and the first free induction decay-based respiratory gating of neonatal pulmonary MR images to be reported. The flexibility to retrospectively select valid data in exchange for SNR highlights a strong advantage of radial UTE MRI. These results demonstrate the feasibility for effective retrospective respiratory gating of pulmonary UTE MR images in free-breathing, non-sedated neonates at multiple lung inflation volumes. Often, pulmonary functional measurements cannot easily be measured in neonates by any other means, so the MRI-based measurements from this work may represent the safest and most accurate measurements available, particularly in the diseased and at-risk infant population. Finally, the authors would like to thank all of our sources of funding, as well as GE Healthcare, for providing MRI research support.